Good evening, everyone, and a warm welcome to the Thursday webinar hosted by the European Trainee Forum focusing on interventional oncology essential for trainees. My name is Charlotte Wintergers, and I'm an interventional radiologist working at the University Hospital Freiburg in the very south of Germany. And today we have 4 speakers with us who will cover key topics in interventional oncology, including ablation techniques, transarterial chemoembolization, TACE, and transarterial radioembolization, TARE, and furthermore the role of IR and tumor boards.
Here we will show a case of CT-guided ablation of a small renal cell carcinoma. On pre-procedure CT, we can clearly identify the enhancing lesion. The central image shows the probe correctly positioned within the tumor under CT guidance. Finally, on post-ablation CT, we observe the treated area with no residual enhancement, consistent with successful tumor necrosis. This is a case of CT-guided cryoablation of a small renal cell carcinoma. On the pre-procedure CT, the exophytic lesion is clearly identified. On the post-ablation CT, the cryoablation probes are seen within the lesion, along with the ice ball, demonstrating good coverage of the tumor. This slide shows MRI follow-up after ablation from 24 hours up to long-term follow-up. Early after treatment, the ablation zone appears larger due to edema and inflammation, then progressively shrinks and becomes more defined.
When planning HCC treatment, we're constantly balancing tumor burden against liver function and patient performance. And curative surgery or transplant is often the goal, but many patients are diagnosed too late to qualify or usually have unfavorable conditions for these therapies. That's where local regional therapies step in. They're incredibly versatile, used not just as a curative option, but for early stage disease, but as a bridge therapy to keep patients safely on the transplant list, or to downstage tumors to meet transplant criteria and prolong patient survival. While guidelines like BCLC give us a roadmap, the reality is that every patient requires a multidisciplinary tumor board, and we must balance the clinical data against the human factors like comorbidities, frailty, and socioeconomic status. And the potential benefits of treatment should, of course, outweigh the risks.
The secret to these therapies lies in the blood supply. A healthy liver is dual supplied, getting 75% of its blood from the portal vein and 25% from the hepatic artery. However, hepatocellular carcinomas are vascular hijackers, deriving 90% of their supply from the hepatic artery. By placing a catheter directly into that artery, we deliver a targeted strike right to the tumor's doorstep while sparing the healthy liver.
That with this, and the radiologist will say, well, we can do that, we can do some ablation here, and then there'll be some surgeon kind of saying, oh, what about this, I think you just have to come along and think, look, what is best for this patient, best for themselves and their outcome. Ultimately, it's great to be the superhero and come in and treat a patient's cancer, but you do have to remember that you should always be thinking what is best for the patient, not for you and your specialty.